Hi, everybody. My name is Boris Eppel. I'm from the University of Chicago, and today it is my pleasure to host this O2M webinar presented by Dr. Martyna Elas. And first of all, I would like to remind you that please switch off your microphones during the presentations, so to make speaker nice and clean sound environment. And after my introduction and the presentation, you will be able to ask all your questions. It rarely goes 15 minutes, it's typically much longer. And finally, the presentations will be finished with some remarks from Dr. Kotecha about upcoming seminars and other changes and plans. So O2M seminars were designed to bring a snapshot of the development in the field, primarily of oxygen imaging technology, but also related fields. And of course, this is connected to advances in cancer and regenerative medicine therapies. There are very distinguished presenters in this series, and please listen for our announcement. And we will start today with presentation of Dr. Martyna Elas. And before I will introduce her, I would like to mention the next seminar in series. It's a seminar of Dr. Sally Pierce from New Mexico Institute, Mining and Technology. She will be talking about the modeling of molecular changes and how we interpret EPR oxygen imaging measurements, which is a very exciting topic. So let's go back to our today's presentation. It is a great pleasure for me to introduce our long-term collaborator, Dr. Martyna Elas from Orlean University in Krakow. And I would like to say that this is the EPR and biophysical measurements in Krakow. It's a very long established program. I don't know, it's well beyond how long I am in science, so it's probably for 50 years. So there are a lot of really great publications coming from Krakow over this last year. So Martyna Elas is specializing in preclinical imaging, especially in the field of anti-cancer therapies. She was doing a lot of studies related to oximetry and a lot of cell signaling and other type of imaging and biological kind of analysis. She has a lot of international collaborations, of course, one with the University of Chicago, but many others, where she can contribute with her enormous knowledge in cancer biochemistry. And she is now Polish coordinator for the large grant devoting to develop of cure for metastatic of uveal melanoma. And she's teaching in Krakow and abroad. And that's what we heard. She's organizing now a workshop and conference, and we are really looking forward for that. Without long ado, I would like to give word to Martyna Elas. Welcome.
Thank you very much, Boris, for your kind words. I'm very happy to be able to present today. I think there is a very nice community around O2M, and I'm very happy to see some faces that I know and some faces that I don't know. Hello, Hal. Hello, Subu. So let me share my screen. Is it visible? Yes? Okay, good.
Yeah, sure.
So let me start by saying that our research interest revolve around tumor microenvironment and oxygenation and hypoxia, of course, and how the tumor microenvironment contributes to tumor development, how it's connected to metastasis and to response to therapies. And today, I think there is a lot of stress and a lot of focus on single cell methods and on viewing tumor microenvironment on the cellular level. So people are following single cells and how they move, how they changed, and so on. But coming from, you know, I spent my postdoc at the University of Chicago, so I totally uphold the view that we have to look at the tumor microenvironment at the tissue level. So we have to look at the whole physiology of the tumor. And I think also recent data support this, that tumor microenvironment is really important, but really at the tissue level. Data like metastatic niche or progenitor cells niches, I think support this idea that the whole of tumor microenvironment, including the biophysical aspects, are very important. And of course, we try to look at this as much as we can in a non-invasive way, using very different imaging techniques and looking how they may complement each other. So today I would like to share our data on two ways of increasing tumor oxygenation. A major part of my talk will be devoted to oxygen microbubbles. Then I will talk a little bit about a hemoglobin modifier that we've been using also to increase oxygenation. And one of the last slides will be on new oximetric spin probes. So what are ultrasound sensitive oxygen bubbles? So they are basically liposomes. The history goes back being a contrast agent. So that's why they are not called liposomes as such, because they contain gas inside, or gas and solution inside, and are reflecting an acoustic wave. So if you put ultrasound transducer to the tissue and put microbubbles inside, you can visualize much better the vascular network, and also you can calculate parameters such as perfusion describing parameters, exactly like in DCE and MRI, basically. But these oxygen bubbles or gas microbubbles, they have also very nice properties because they can oscillate when you put them under the acoustic wave. They can oscillate, and these mechanical effects can generate microstreaming and microjets. So it's basically as if you put the little mixer into the vasculature, and that makes the transporting drugs into the tumor tissue or transporting DNA or RNA into the tumor tissue much easier. Finally, if you give enough power, you can burst the bubbles, and then you can get even the cavitation effects. So we wanted to use these properties and see if we can deliver oxygen into the bubbles. And of course, there are several groups trying to do just that, and they were quite successful, but what we saw in the literature was that, the longest time for the oxygen increase was about 5 minutes. So we wanted to produce better microbubbles. This was done in collaboration with Professor Chantal Pichon from Orlean, France, and Anthony Delalande from his laboratory, and experiments were performed by Agnieszka Zhao from our lab. So first of all, we look at the stability of oxygen microbubbles, and as you can see, in a viscous solution, the size of the bubbles was around 2 microns. And after the disruption by sonication, we could see much smaller fragments. But if you don't use the ultrasound pulse, you have the size is pretty stable. So we also didn't find any bigger bubbles than 6 micrometers, so they are pretty safe to inject intravascular. And in terms of oxygen leaking, we were a little bit worried that in solution or in vivo, they can leak oxygen outside. However, it turned out that they were pretty stable in terms of containing oxygen inside. Here you can see the oxygenation measurements within the solution. Here are nitrogen-filled bubbles, and here is the ultrasound pulse to burst them, and there is no increase. And here are oxygen-filled microbubbles. The initial oxygenation is pretty high. This is resulting from mixing solution. So there is some oxygen as a baseline. But then when you give the oxygen pulse, the oxygenation increases dramatically and really is pretty high. So we were confident that our bubbles seems to be working and wanted to see how it looks, how it works in vivo in the tumors. So we used orthotopically injected breast cancer, murine breast cancer, 41. And we wanted to test 2 different ways of bubble administration. Intravascularly, and we give about 100 microliters of the microbubble solution. This is above 1 million bubbles. And intratumorally, of course, we could give only smaller volume. So it was only 20 microliters in a few injections, in few separate injections directly into the tissue. And then we wanted to measure oxygenation. And we did it in 2 ways, using our Bruker L-band imager. We did 2D spatial imaging using carboxyproxyl as an oximetric spin probe, and then to elucidate the mechanism using many different control groups. We did the kinetics of oxygenation, how it changes in time using oxygen. So here are the results from the imaging experiments. And as you can see, the control was pretty hypoxic. And when tumors were injected intratumorally, or if the bubbles were given intravascularly, we already see some increase, and even more if the bubbles were burst with ultrasound. And even with the nitrogen bubbles given intravascularly and with ultrasound pulse, we could see some little increase in oxygenation, especially at the periphery of the tumor. If you look at the average value from all the image, you could see increase in all the groups, in all the treatments, and the histograms also confirm this, that there is increase in oxygenation across all the groups. So as I mentioned, thanks to collaboration with Dr. Kupusami, we could use Oxychip for more detailed measurements, because, let me go back, because our imaging takes a much longer time. So we have to average the information, the oxygen information from an entire tumor volume and over the whole time of acquiring the image, which is approximately 30 minutes. So that's quite long. So to look at the mechanism, we wanted to check how the oxygenation changes in time after giving the bubbles, the microbubbles, and how it changes between the groups and with time. So here are the results, and we could see that indeed the oxygen was released in the tumor after bubbles and ultrasound, but also in other groups that didn't have the ultrasound. So the maximum increase was, of course, in the oxygen bubbles plus ultrasound pulse group, and you can see that it reached about 100 torr and decreased over 20-30 minutes. Even after 30 minutes, we still have around 20 torr oxygenation within the tumor. And then the bubbles without the ultrasound pulse, they release oxygen much slowly, but the increase is around 40 torr. And the vehicle itself, so no bubbles, no pulse, also give a little bit increase up to 20 torr, but decreases very quickly. And this group was a big surprise when we give nitrogen-filled bubbles and give ultrasound pulse, because no oxygen given, no oxygen added to the system, and we still could see an increase to approximately 20 torr, whereas control was a few torr, 3 or 5 torr. So this was very interesting, and similarly, here are the results for intratumoral injection. So the maximum was around 80 torr, maybe decreasing a little bit faster, but again, after 30 minutes, we could still have perhaps around 10 torr. And oxygen bubbles around 40, and also nitrogen filled bubbles also gave a little bit increase around maybe 50. So we were trying to understand these effects and to see what are the contributions to the observed increase, what are the different sources of the increase of oxygen. So based on our measurements, we think that nitrogen bubbles and ultrasound pulse show the effect of interaction between bubbles and ultrasound and all the cavitation and micro streaming and mixing in the vasculature. So this is some residual oxygen that's there, but has to be pushed into the tumor, right? So in the intravascular group, there was about 20 torr. In the intratumoral, much less, because there was less vasculature that the bubbles were exposed to. There is some big component of oxygen coming from the vehicle in which the bubbles are suspended in. So this is approximately 20 to 30 torr. And of course, there is oxygen contained in the bubbles themselves. That's between 20 and 15. And then there is the component that comes from using the pulse, the ultrasound pulse, and pushing and mixing the bubbles into the tissue. So in intravascular group, this is again the bigger component than in intravascular group, intratumoral group, because there is bigger intravascular surface that can be interacted with. So we were pretty confident that the increase was real, and it lasted 20 minutes. That might be enough for radiotherapy to occur, but we wanted also to see if we can observe any other physiological effects of this treatment. And indeed, we saw the increase in hex leakage. So if you give the dye, the hex dye into the vasculature, you can then sacrifice the tumors and look how much the dye leaked out and how far it could go. And as you can see, there is some purple in the control groups and in the microbubbles without the ultrasound groups, but there is quite a lot of the purple color here in all the groups that were treated with ultrasound pulse. So that confirms that we are destroying the vasculature, or that there is interaction between bubbles and ultrasound that breaks the vascular wall, and there is leakage and there is some destruction of the vasculature. Here is the quantitation of these images, and as you can see, the biggest increase, I think, is in the periphery of the tumor, where there is more vasculature in general, and in this tumor model also. We also looked at the structure of vasculature and to see if there is some remodeling. As these tests were performed just 3 hours after the microbubble treatment, we didn't see much difference in the vascular density or in the vascular diameter. But I was really delighted to see less parasites. These are cells that are connected to angiogenesis. So if there is less parasites, then that means that angiogenesis is a little bit inhibited. So even 3 hours after the treatment, and especially here in the group of oxygen bubbles given IV with ultrasound, we could see a decrease in vascular remodeling. In agreement with this were also these results. Here we can see the VEGF concentration. And again, as we could see the increase in oxygenation across all the groups, the same here, we could see a decrease in VEGF in almost all groups, and especially the biggest decrease in the, again, oxygen microbubbles given IV plus ultrasound. We also looked at other hypoxia markers, and like GLUT1 or HIF1 alpha, COX2 is an inflammation marker, and we also could see some decreases in these protein levels. So that was a clear mark that that there is response to this oxygenation increase within the tissue, and pretty fast, as I mentioned, 3 hours after microbubbles. VEGF in particular is a very fast and very important modulator of response to hypoxia. So we were really pleased to see these results. Of course, if you give a lot of oxygen suddenly into the tissue, that might cause some toxicity. So we wanted to check if giving microbubbles is toxic. Of course, we did only a single injection of bubbles, but we looked at 3 minutes, 30 minutes, and 3 hours. Here is the aspartate transaminase and creatine kinase. So we wanted to see if this is toxic to liver or to heart, and we didn't see any acute toxicity. There is some little increase in oxidative stress, but this is only in heart after 3 minutes of after IV injection, and in the tumor tissue. So this was done using MDA, common marker for oxidative stress in the tissue. We also looked at the protein and DNA oxidation, and basically it was negligible. Here again, in the heart after 3 minutes, and in the tumor a little bit increase in oxidative stress, but that was quickly gone and not visible after 3 hours. And of course, the crucial experiment was the radiation experiment. So we wanted to see if there is radiation sensitization by this all this oxygen that we are supplying to the tumor. So we did radiation using gamma irradiation 12 dose, single dose on day 7, 5 minutes after injection and disruption of the bubbles. Some groups were without the ultrasound pulse. So as you can see, the control is radiation only. This is gamma radiation only. And all the other groups, whatever the treatment, we could see almost equal radiosensitization, almost equal tumor growth inhibition. And of course, this agrees with our oxygenation data, because in all groups, we were above the threshold of 20 torr. So there was enough oxygen to radiosensitize in all groups at 5 minutes post bubbles, you know, so it did make sense. However, not everything was really tight and lovely as we would like to, because what we saw was an increase in the metastasis to the lung. So as you can see, the black boxes here, they are all higher than the control. And we would expect, of course, the metastasis to be higher in groups where we have clear disruption of the vascular wall. But unfortunately, we could see the increase in all the groups. So as we saw increase in oxygenation in all the groups, the same we see it correlates in the increase with metastasis. And we are not clear as yet about the mechanism. We want to look into this deeper and see perhaps a different tumor model to confirm this, because this is really a serious hindrance to implementation of oxygen microbubbles into the clinic. So I hope during the discussion you will have some suggestions for us. But to conclude this part, I would like to say that we can effectively increase the oxygenation of tumors, even if it's for a short time, 20 minutes, 30 minutes, perhaps some different construction of the lipid shell can give us even longer effects. And we could see the radiosensitization to radiotherapy. Unfortunately, we see a higher metastatic burden, but we see also changes on tissue and molecular level, increase in vascular leakage, some inhibition of angiogenesis, and decrease in hypoxia protein markers. So now I would like to move to a second way that we use to increase tumor oxygenation. This was done in collaboration with Claudine Kieda from University of Orlean, and experiments were performed under the direction of Martyna Elas from our lab. So Claudine is working on a derivative of inositol trispyrophosphate called ITPP that shifts the hemoglobin saturation curve. So when you have ITPP in the presence of blood or in the presence of hemoglobin, it releases more oxygen into the environment with a lower oxygenation saturation of hemoglobin. And our colleagues from Bernard Gallet lab, they performed some experiments using ITPP and working with Claudine, and they checked several tumor models showing some increase in oxygenation. And we wanted to see if in our models we see the same effect. So we were looking at two immunocompetent models, again, 41 murine breast carcinoma and also B16 murine melanoma. And ITPP was given in several doses IP, for example, on day 5, 6, so within 24 hours, then break, again 12, 13, and then break 19, 20. And we tried with different setups, different intervals between the injections. And again, we used Oxichip from Kupu as an oximetric probe. And we either implanted the Oxichip after the tumor reached, approximately 3 millimeters in size, or injected it together with the cells when implanting the tumor. So here are results from the breast tumors in mice, and we present them not as individual curves, but as a group results. And here the light blue color shows the higher than 10 TOR readings, and dark blue shows hypoxia. And here you have the time scale. So this is before ITPP, between the 8 and 11, 12 to 16, and more than 16. So as you can see in the ITPP group, you can see that there is some window in time of tumor growth when the tumor becomes better oxygenated, and this is also visible here in the histograms, that there is clear shift in oxygenation in comparison to untreated control or control treated with the vehicle. And here it's slightly different dosing, but the results are maybe less pronounced, but also visible. So here we have slightly more oxygenated tumors. And similarly in the B16 tumor model, again, we can see an increase in oxygenation, less hypoxia in the ITPP treated group. And here the Oxichip was given a little bit later, that therefore we don't have all the time slots, but we also could see that there is better oxygenation in the ITPP treated tumors. What was also interesting in this experiment was in the series of experiments that ITPP seemed to be slowing down a little bit of the tumor growth. And it wasn't visible when we have all the tumors together, but if we divided them into two groups, and hypoxic before starting the treatment, and more normoxic when starting the treatment, so above and below 10 TOR, we could see that there is some slowing down, which is maybe more pronounced here in B16 tumors, where normoxic tumors are growing even faster, and then control, and here the hypoxic tumors slowing down. And this effect was also observed by others working with ITPP, that this treatment is maybe slowing down tumor growth. So concluding this part, I have to say that long-term ITPP treatment results in higher tumor oxygenation. The increase is much less pronounced than microbubbles, and but has a different time scale, right? So this is more long-term treatment and with little increase in oxygenation, and also temporary increase, so for a few days. But this perhaps might be enough to give tumors a different treatment. Right now, I know that ITPP is being studied in the context of immunotherapy that might use this higher oxygenation window. And also we showed that ITP treatment inhibits growth of the hypoxic but not the normoxic tumors. And of course, we work with oximetry, we work with other EPR techniques, and as we all know, we still need some new oximetric spin probes. And here, in collaboration with Dr. Bobko from West Virginia University, we have tried to use some crystals that were either bare or coated with some different types of coating to see if we can use them for imaging. And as you can see,
your work.
There are some, these are the intensity images. And here we have the 2D spectral spatial images. These are E0771 tumors, also breast, murine breast carcinoma. And as you can see, as the tumor grows, the oxygenation goes down, but we could see the signal pretty clearly from the whole tumor volume still after day 40. So I think it was very satisfactory, and we hope to develop this perhaps further. So I hope I convince you that we can use EPR oximetry, and it is a wonderful tool, and I'm sure we can find many more important applications or applications that will be relevant to the clinic. I would like to thank all the people that were engaged into studies from our Department of Biophysics. Agnieszka Żał, who was responsible for the Bubble project, Martyna Elas for ITPP project, all the other people involved in our studies, and our wonderful collaborators from University of Chicago, from Orlean, from Dartmouth Medical School, and from West Virginia University. And we did our irradiations at the Institute of Nuclear Physics in Krakow. And I would like to finish with the announcement of the date for the next workshop on EPR application. So hopefully we could see you in Krakow next October next year, between 10th and 14th. And we hope that you will be able to come and enjoy Krakow and enjoy scientific discussions. But we are planning to do this both locally and online. So we hope that the talks and discussions might be also online available for those who won't be able to come. So with this, I would like to finish, and thank you very much for your attention.
Thank you, Martyna, for this great presentation. I'm sure there are questions which we can ask you. So,
Martyna.
Yes.
Hi, that was a wonderful.
Art.
Hi, that was a wonderful presentation.
Thank
look,
you.
one thing. It is obviously the completeness of your discussion and the attention to the side effects from the vascular disruption is critically important. I'm wondering whether or not including with the oxygenation of the solution of the microbubbles some cytotoxic chemotherapy, maybe even mild cytotoxic chemotherapy, might modulate the metastasis increase that you see, and perhaps that would in fact give additional toxicity, local toxicity, to the tumors as well. So trying to address the metastatic effect that you had.
Yes, that's a very good suggestion. So you think that if we give some chemo together with the bubbles, then we can kill also the circulating cells, right?
Yep, that's exactly right.
Yeah.
That are liberated by the vascular disruption.
Yeah, this is a very good suggestion. Yeah.
Okay, and anyway, beautiful talk.
Yeah. Along that same line, starting again, a great talk and really exciting to see. When you did the ultrasound, was it localized to the tumor, or was it the whole? And how you're confident that it was really well localized? Because
that's right.
Mice are small. Yeah. Okay.
Mice are small, but we had the transducer that was like 1 centimeter in diameter, and it was very focused ultrasound pulse. I didn't give you the particulars. There was 2 microwatt, I think, and in power, and was pulsed with certain frequency and for 1 minute, only to the tumor area.
Martina, question.
Yes.
The microwave pulse the ultrasound, pulse optimization. So the effect of disruption of the vasculature is the intended effect, or it's a side effect? So was it optimized for that and other? Yeah.
This is a good question. So I think it's a little bit too much what we intended, right? Because normally it's possible to see if bubbles or maybe nanobubbles of less size, smaller size in diameter, they can even break the cellular cellular membrane, enter into the cell, and then the membrane will seal up back again, you know. So I think this is absolutely the question of optimization, both in terms of the amount of microbubbles and the strength of the ultrasound pulse. Definitely. We were trying, you know, our goal was to get as much oxygen as we could, because we thought, you know, that this won't be very effective, you know. So perhaps this vasculature, this disruption can be decreased by optimizing the ultrasound pulse.
Yeah, ultrasound, of course, is used as a cytotoxin itself. High focused ultrasound is used as a local treatment for tumors. So far, it's actually been used in benign tumors in humans, but it is a very common way to basically shrink fibroids in a non-invasive way, uterine fibroids. So yes, and reducing the ultrasound might be an optimal way to deal with that. That's I think very wise.
There is a question in the chat from Muruksen Velatham. What is the effect of microwave on microbubbles?
I'm not sure there is any, because I think, you know, well, that's a good question. I'm not sure. Actually, I don't know. Microwaves on microbubble.
It's an alternate means of heating, so that in that sense it might be additive or an additional.
Absolutely, yes.
Effect.
Yeah. Yeah, perhaps we have to look into that.
Martina, may I ask you one more question?
Of course.
You was showing data both from the spin probe, from the localized particulate, and the imaging results, and also the Hurst staining. is her staining correlates with two-dimensional imaging results? So you mentioned that periphery seems had a better release of tumor rather than the core. So are they correlated between themselves well, this modality?
Well, we didn't plan the experiment to correlate this to register the images or to correlate, but yes, definitely we see more vasculature at the periphery of the tumor. And basically, I can share again if you want the screen, we could see even in our 2D, Bruker images, which do not have good resolution, we could really see that the periphery was much higher, much more, higher oxygenated than the central part of the tumor. So we think, yes, that is the correlation, but we don't have this is not, oops, sorry. Okay, so here, if you can see, this is on the edge, here you can see on the edge, and here you can see on the edge. So perhaps.
Thank you.
Can I ask about your HIF-1 alpha staining?
Of course.
Did you see expression in the nucleus and cytoplasm? Were you able to distinguish it well? Because I'm trying to do that now and it's difficult to distinguish.
Yes, it's very difficult. We didn't do this by staining. We did it by Western blot. So this is just homogenized. This is not spatially, but this was the test for the nuclearly located HIF-1 alpha.
Oh, okay.
All right.
Maybe I'll try that. Thank you.
I see one more question from Eugene Bart. Can you expand on where the source of the oxygenation with nitrogen-filled bubbles plus ultrasound?
Yes, well, for now it's just speculation, Jean. So if we give the injection of nitrogen perfused bubbles, well, nitrogen containing bubbles, and the vehicle is also nitrogen perfused, we don't give any oxygen to the animal. We only give bubbles and ultrasound pulse. So that means that if we see the increase in oxygenation, it has to come from the inside. So what I think, there is some oxygenation that's in the vasculature or in the tumor tissue, and just mixing it, using the bubbles with the pulse causes the increase around 20 torr. So that's what I think, but perhaps we have to do some more experiments to be sure of this.
Hi, Martyna.
Hi, Benoit.
It was a very, very nice presentation. So for your oxygen image, so you have a drastic change in oxygenation during your acquisition time. So how can you be confident? How does it affect the oxygen image to have like this much change in oxygen during your?
Yeah. That is a very good question. That's why we did Oxychip, and all the numerical stuff is based on Oxychip measurements, because that's accurate. Our images are just, very much average over the time. So.
Okay. And in relation with what Howard said, so is it possible to dissolve a chemo inside the lipid phase of your?
Yes, actually, bubbles are very much used for drug delivery, and very successful actually in drug delivery. But I'm not sure. It has to be something that's not sensitive to oxygen presence, right? And also the generation of oxygen microbubbles requires a certain procedure, because you have to use perfluorocarbon first, and then you dry it, and then you give oxygen, and you have to activate the bubbles and so on. So it will have to be built into the procedure, but I think it might be possible. Yes, that would be very nice.
Thank you.
Thanks.
I have few questions. Can I ask? Yeah.
Yes.
I am working at O2M. My name is Naveen Vishwakarma. So, it's known as like solid tumor is like, with lots of desmoplasia, is known as like sword with the two edges. You don't want to disturb sometime hypoxic region because it disturbs the, all the, they can go and metastasize. But like Dr. Howard told, it's a good idea to infuse chemotherapy along with your microbubbles. Here is like one idea, like we can do, like you can use a doxorubicin, let's say nanoparticle coated doxorubicin, and when you inject that, when you do the microbubble injection along with the doxorubicin, because doxorubicin fluoresces, and you can see the tumor whether this is the drug is delivering there or not. Because the main issue is if this microbubbles can help in making more vascularization, and if it can help in drug delivery, then it's a wonderful approach, because then that will help us to show, okay, well, fine, this microbubbles not only opening the vascularization, it's also helping in drug delivery.
Yes. So, absolutely, yes, that's very nice. Yeah, what I wanna check also is to see if the bubbles go where there is no vasculature, right? In the most needed areas, right? I mean, do they go only where there is some microvessels, or do they locate also in the tissue when there is no vasculature at all? That's I think it's the big question right now.
Yeah. And in this case of this CB1, whether this probe was inserted into the tumor when you did this oximetry?
No, it was implanted together with the cells at the time the tumor was implanted. The cells were implanted together with the probe.
Okay.
And did you do MRI to localize where the probe is compared to tumor?
No, we didn't do MRI. We unfortunately don't have that possibility at our building, so we have to take our mice and drive quite a distance. So with this experiment, we didn't do that. We just look at the signal basically.
Wonderful talk, Martyna.
Thank you.
Okay, please, if somebody still have questions, it's a time
yes,
to ask.
so anybody got any ideas why there are more metastases when the oxygenation is increased? Not necessarily due to disruption of vasculature.
Tumor cells needs oxygen to grow, and if it sees oxygen, I believe that is a good chance that they will find they are happily growing, and they will try to go to the different tissue. So oxygen is good, but at the same time, it's giving it chance to escape from the primary resident area. So it's and lungs is the first of the organ where it gets metastasized. So that's why it's a very good idea that using the microbubbles along with some drug, I mean chemotherapy or immunotherapy like checkpoint inhibitors. People with immunological field, they are finding difficult that how to, like for example, in a pancreatic tumor where it's very dense pancreatic tumor, they are finding difficulties how to increase the vascularization, and then they want to inject the checkpoint inhibitor drugs or something, and that will be, I hope it will shrink the tumor very nicely. Yeah. I mean, there are lots of questions, but yeah, I think this is a good point to start with.
This is Marty Pagel. I don't have a really great answer to your question, but it is an interesting topic. I think you also, the reasons why metastases occur is extremely complicated. You can have a lot of circulating tumor cells in the bloodstream and yet nothing metastasizes, or vice versa. So it's almost like there are processes that cause some cells to become like the commandos or super revved up cells that do metastasize, and why your oxygenation is causing those commando cells to appear. That's very difficult to say, in my opinion. It's a great question, but very difficult to answer, unfortunately.
Thank you.
Is there any chance like these microbubbles cross blood-brain barrier, nanobubbles?
Yes, they do. Yes, they do. There is some work done on microbubbles crossing the blood-brain barrier.
I have a quick question. I'm Gianpaolo Vallerini from O2M. Is your bubble producing technology and oxygen filling of the bubbles applicable to already existing and used liposomes particles to deliver drugs or stuff or something like that? Meaning,
yes, I think the composition of the shell usually is more enriched with the microbubbles. So usually there is something inserted to make it more tight or more resistant to bloodstream disruption or something like that. So usually they put some stuff, some more stuff than just plain lipids. That usually there is something more. Ours are pegylated and have 2 or 3 other components.
What would happen if you use your sonication technique to disrupt a branded liposome?
Yeah, they burst.
So you can apply oxygen.
Oh, you mean the liposome? Well, the difference is you have to have some gas inside, not only solution, right? Liposomes usually have some solution inside. We have solution in gas, so they are more springy.
I see. But you did show that your nitrogen filled bubbles burst and then there's oxygen increase, even though less extent. So
yes.
Wouldn't that happen also with liposomes? Or it doesn't happen because there's no gas inside?
No, because they don't oscillate as much,
I see.
They have to have the mechanical properties, and I don't think liposomes have that. So I think that is probably the difference between why we call them microbubbles and not liposomes.
So it would have to be like a different building setup since the beginning. Like if you want to include a drug in your microbubbles, you have to make a microbubble with a drug. You can't.
Yes.
You can't turn a liposome filled with a drug into a microbubble.
No.
Okay.
Well, I don't know actually, because I'm not that much into the building procedure. That is done by our collaborators. So I'm not sure, but maybe it's a simple thing. I just don't know.
Okay, thanks.
Do you have oil phase or aqueous phase inside your liposome?
I think both. There is both gas and solution inside, but there has to be. I mean, there is quite a lot of gas inside to make them, oscillate.
So you have oxygen in gas phase. It's not dissolved oxygen.
I don't know really, I don't know. I did the calculation for the gas, for the solution phase, but I think it needs, there is some mixture of both, it's not just a clear, like there is a distribution in size, there is some, they are not very nice, you know, all the same looking microbubbles. I think this is just like a soup, you know, that has all in this. There are some with gas, some with solution, some both, you know, that's what I think.
Okay, I think it was a really fruitful discussion, and let's thank Martyna again for this wonderful presentation.
Thank you, thank you.
Very nice talk.
Let's bring Nani gift.
Thank you all for joining. I'm so glad we can do this, and I'm so happy to see everyone. And I hope next month we will have Dr. Sally P.S. on November 11th. I believe it's 11 a.m. CT, and I hope you all again will join us and tune in, and we'll hear exciting talk again. And thanks, Martyna, for presentation and wonderful talk.
Thank you. See you guys next time.
See you next time.
Bye bye, everybody.
Bye bye, Martyna.
Bye.
Bye bye.
Bye bye, Martyna.